Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
We're going to be discussing bridging science and support, initiating biologics in our HS patients, and how to do that with confidence. So let's dive in. What are some tips for early recognition of HS and overcoming the misdiagnosis within that first encounter with your HS patients?
Yeah, so that's a great question. I think misdiagnosis or missed diagnosis is really such an important issue with HS. The average delay of diagnosis is 7 to 10 years with this disease. It's getting better because I think awareness is getting better, but we still see a lot of folks miss the diagnosis. So there's actually one question that you can ask to give yourself a 95% likelihood of a diagnosis of HS versus not, and that is simply whether or not the patient has had in the last 6 months 2 or more episodes of an inflammatory nodule or papule in the body fold area, okay? And so that was actually validated in a European study about the epidemiology of HS. So pretty simple, and I think for a dermatology audience, I think we're pretty good at the diagnosis, but it's helpful to be able to put that into words for our colleagues who maybe aren't as familiar.
Absolutely. I love that.
So can you talk about why it's so critical to have that early diagnosis? And with that, does it change the trajectory of a patient's disease?
Yeah, it has a potential to change the trajectory of their whole life, right? So I think anybody who's seen HS knows that the quality of life impact of this disease is worse than just about any other that we see in dermatology. Just really life-altering, impact in terms of work, relationships, and on and on. And so the earlier we can get patients to evidence-based therapy, the better for them. There certainly is the notion that if you see a patient with early stage 1 mild HS and you're not treating them, that or they're not seeing you at all, that over time, that they will progress to early 2 or early 3. But certainly the scars, the tract formation, those things happen when we're not treating the disease. And there's more and more information coming out about what we might term a window of opportunity, which is that we want to be more aggressive earlier so that we can spare the patient developing some of these more difficult phenotypes that, frankly, we don't have good tools to address right now.
So walk us through your conversations with patients whom you've diagnosed with HS. Like, how do you educate them on this condition? How do you not scare them about the future, but talk to them about the chronicity of this disease?
Sure. So, I think that the first thing is actually just giving the patient some space to, talk to somebody who has actually known something about the disease, right? So they, keep in mind, have been bounced around. Sometimes they've been told by other providers, you're too fat, just lose weight. This is a hygiene issue. You need to quit smoking. Those things may all have, the weight and the smoking may have some relevance, and we can talk more about that. But this is not the patient's fault, okay? And I think it's really important to provide the empathy to gain the trust of the patient because that's going to be necessary to be successful long term. I think that in that first visit, the main take-home point that I'm trying to leave the patient with is that we're going to help them, right? If they're coming to you with more or less a blank slate, like almost anything that we are going to do is going to help this patient. It's going to be a process. We need to be, in it together on the same team. It may be iterative over time, but the message I want to give them is that we will get there.
Giving them hope.
Absolutely, hope is essential for this condition, for sure.
So let's review some of the kind of historic treatment options for HS, and let's kind of dive in a little bit deeper into the FDA-approved therapies that we currently have.
Sure. I think that for patients with early stage 1 disease, mild to moderate HS, and also really from an insurance approval perspective, right? We're mostly going to be starting with doxycycline, spironolactone for female patients. Certainly those therapies can be pretty effective for, again, the mild to moderate HS. Any treatment, just like with acne, any treatment's going to take about 3 months to be able to assess kind of where we're at. It's a waxing and waning condition, so we want to give the therapy time to kick in and also have enough sample size of time elapsed to be able to tell, is it randomly better or randomly worse, or what is the actual trajectory here? Certainly, we'll also do, topical, wash like chlorhexidine wash, topical clindamycin. Many of us are using resorcinol, which can be compounded in a specialty pharmacies, 15% resorcinol cream for flares. And so, of course, there are other antibiotic regimens that are out there. Certainly, there's interest in other hormonal therapies. Metformin, GLP-1 inhibitors have some interesting preliminary data. But for the mild to moderate patient, we're kind of sampling really some therapies that have been around forever. So if anybody wants to do any pharma companies out there want to do some studies on those patients and not only our more severe patients, there's a huge need there. But that's where we're starting. And certainly that's going to be our entry point to getting access to biologics, be able to say these patients been on, say, doxycycline for 3 months, hasn't worked. Now we should be able to get approval for our biologics.
So, what is the right time to start biologic? And do they, in your mind, have to fail a lot of those other things first?
Well, I said a moment ago, the window of opportunity concept is a really important one. And I think that in general, obviously each patient is going to be a conversation, but in general, globally, we are not doing a good enough job of getting patients onto effective therapies. There was a study, a little bit older data now, but basically they looked at patients with HS in a claims database and basically asked the question, what percentage of patients were receiving prescriptions for, at that time, adalimumab or infliximab? And if we think about how many patients have moderate to severe disease, it's about 1/3 of patients. The other 2/3 have mild disease. So 1/3 of patients with HS would be eligible for a biologic. And in the study, only 1.8% of patients were actually receiving prescriptions for a biologic. And so not only do we have a diagnosis gap, we also have a treatment gap. We're not getting patients who need the therapy onto the right therapies. So I would say earlier is better in general. I think that obviously if I don't have to immunosuppress someone, I may feel very comfortable with these drugs, that weighing out that risk and benefit is usually an easy call. But if I don't think they really need a biologic, then I'd rather not immunosuppress them. So that's a conversation, obviously, in the gestalt for you as the clinician. But I would say don't dilly-dally, right? Like you don't need to prove to yourself that, every antibiotic you can think of doesn't work. You can move to a biologic sooner than that.
Yeah.
So, unlike a lot of the inflammatory diseases that we have right now, psoriasis, atopic, where we can see, 100% clearance rates, how do we kind of manage our expectations as clinicians and also that of patients when it comes to clearing or controlling disease?
Yeah, I would say, I hope for a day when there's high score. High score is our metric, not PASI. High score 50 is 50% improvement, high score 75, high score 90. I hope for a day when there's a high score 90, high score 100 is like a routine thing that we're seeing with our drugs, but we're not there yet. And so, again, we start with just saying, listen, we are going to start making you better, right? Like we are going to start to move this in the right direction. But and I can quote the data and say, this is what we would see in general, in terms of efficacy, what percentage of patients and so on. But for that individual patient, we don't know till we try, right? So I think that especially as you get into patients who maybe haven't responded to the first biologic that you've tried, it's really important to say, and this is what I literally say to my patients, I'm never out of ideas. There's always something else we can do. Okay, again, getting back to the hope concept. But it's going to be a trial and error process. We're going to need to troubleshoot with the dose. We may need to try a different mechanism of action. But again, I have confidence that we will get there or we will make the patients significantly better than where they started. And it's important, again, for them to really believe that you're in there in that with them and that you have a plan, a plan B, a plan C, a plan D, if it takes that many plans, for them to kind of stick it through with you to get to that final result that you're looking for.
And I have found, like with the HS patients, they will stick it through with you. If they trust that you're really doing your best and putting in that effort, they tend to stay by your side.
Yeah, again, it's hard to overestimate, the quality of life impact of the disease. So I think patients are willing to, go through quite a lot in terms of giving themselves injections and, dealing with complicated regimens sometimes in order to get relief from the condition that's, an ever-present drag on their quality of life. So absolutely, that's true.
And they will have that buy-in if they start to get that relief and start to see that success, of course. And we know the trajectory as clinicians, and we're afraid of that train going down that track. But how do you discuss with a very fearful patient that's not ready to take that journey and that jump into biologics? Maybe they're needle phobic, or maybe they're worried about long-term side effects or
Mhm.
immunosuppression. How do you have that conversation if you really believe that they need it?
Yeah, I mean, every patient is different and you have to meet them where they are. So you just listed a few different reasons why they might not be excited about starting a biologic. And it's helpful to ask them what their reservations are. But I think, it's like any other medicine when you read the package insert and it's like, 50 different potential problems. It's hard to wrap your head around that. But I do like that sort of scale analogy, which is that, we have, let's say, tuberculosis, right? So, the risk of reactivation of tuberculosis with a TNF inhibitor. Okay, so that's bad. We don't want that to happen. It's very, very uncommon, right? We check for it before we start. We check annually. Still, even though there's data maybe even that we don't need to do that, but we still do it. And I can say that, this is a very rare event. Weighed against the every single day impact of the disease, and it pretty quickly becomes an easy call for the patient to make. It's okay for you to be vociferous, to say to the patient, listen, I really think that this is what you need to do. This is a condition that we need to treat aggressively to get you where you want to go. And I think it's okay to say that. I think sometimes the patient has to prove it to themselves. They may want another 3 months on whatever. But again, that kind of regular follow-up, regular conversations, I think most patients will certainly come along.
So when we do have treatment success for a patient, sometimes they ask that dreaded question, when can I stop? Right. So how do you approach that conversation about the chronic nature of HS and long-term management?
Sure. Yeah, it's important for patients to know that it is a chronic condition, that we don't have a cure yet. I do tell them, if they were to ask me, am I going to be on this medicine the rest of my life? I'll say, no, I don't really think so. Like any other autoimmune disease, it can burn out over time and be less active than maybe it once was. The trouble is I can't tell you when that's going to happen, right? And so what I'll tell a patient is, listen, if we're finding, the whole name of the game is a chronic condition, we're looking for a therapy that works and that is safe and well tolerated, because you're going to stay on it long term if it's doing what we want it to do. And most patients, frankly, it's hard for them to imagine, but when they get to a point where they're in a good place, they don't want to stop the drug, right? But I will tell them, listen, if you're doing really well for a really long time, we can try to back off. There's some intricacies about drug level monitoring and other things that some people talk about, but it's obviously a conversation. It's a case-by-case basis. And I do think most patients will eventually not need therapy, but it could be, years down the road.
And that's
Yeah.
a great problem to have, right? If we get to that
Yeah,
point.
it's a good conversation to have the luxury of having, certainly.
So we are so grateful for you and your knowledge, and thank you for walking through a lot of these conversations and shared decision making, points and tips. We just really appreciate you being here, and thank you for joining us.
Sure,
Thank you.
my pleasure. Thank you.
The enduring content of this episode is sponsored by UCB.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.